behalf of CAHO and Diagnostic Division, we welcome all our speakers, moderators, and delegates to enjoy this feast on topic of autoimmunity and celebrating the awareness of autoimmunity. So, without taking more time, I really open this webinar series of lectures for all of us today and wishing all of us best of luck. Thank you so much. Over to Dr. Simi Bhatia. Ma'am, over to you.
Yeah, thanks, Aparna. Welcome to all of you. 20th May 2012 was the day when the International Foundation for Autoimmune and Autoinflammatory Arthritis decided to initiate the World Autoimmune Arthritis Day. And this was in 2012, and today we are in 2024. And as Dr. Aparna shared, that it was always there. It is just that the diagnosis, the tests available, and the awareness for these facilities is slowly on the rise because laboratory has worked hand in hand with clinicians to ensure that they can get those diagnoses right. Now, the main aim of this day is to create awareness and to the community, as well as to ensure that people who are suffering from arthritis around the world get the right treatment. Today, when we start our series or the first talk on Autoimmune Day, we are going to concentrate on the collagen vascular disorders because autoimmunity, as all of you know, can hit any organ. And today we are going to concentrate on just the collagen vascular aspect of it, for which we have three speakers. It's my privilege and honor to introduce Dr. Ajay Gupta, an ex-colleague of mine, extremely passionate about autoimmunity and extremely well-read. Dr. Ajay Gupta is the Technical Director of Hematology and Immunology at Dr. Lal Path Labs in Delhi. He's also heading the initiative which Lal Path Lab has started of the Autoimmune Center of Excellence. So, Ajay, welcome to this forum and thank you for accepting my offer to be a speaker. Over to you.
Gupta, and many thanks to the organizers and all those who are attending this webinar series of webinars. And today I shall be dealing with diagnostic advances in autoimmune disorders. We all know how common have these become, and the incidence has steeply risen post-COVID area. Now, it can be because of post-COVID per se or post-COVID vaccination, we don't know, but the incidence in total across the globe has risen. And definitely, when we talk about autoimmune diseases, now they are very, very complex and not easy to diagnose. Some of the index journals have published the data that the time of the first onset of symptom of an autoimmune disease to the final diagnosis, it's about 2.5 to 3.5 years. So you can see how these diseases they behave, and they are mainly divided into organ specific and systemic autoimmune disease. We all know about autoimmune disorders. There's lots of self-tolerance leading to the production of autoantibodies, which reacts with their own antigens, and they are divided into organ-specific and systemic autoimmune disease. We all know about organ-specific autoimmune disease. The worldwide Hashimoto's thyroiditis is the most commonest of all organ-specific autoimmune disease, and rheumatoid arthritis being the most prevalent among the systemic autoimmune disease. Definitely, when we talk about organ-specific autoimmune disease, virtually each and every organ of the body is involved, right from thyroid, pancreas, kidney, RBC, liver, skeletal muscles. So each and every organ is involved, and the autoimmune diseases per se also involve specific organs. And the systemic autoimmune disease now, lupus, rheumatoid arthritis, antiphospholipid syndrome, systemic sclerosis, Sjogren's syndrome, vasculitis, and inflammatory myopathies. Rheumatoid arthritis is worldwide most prevalent among the systemic autoimmune diseases, and testing for screening and diagnosing these diseases will be in focus for today's presentation. That what are the various diagnostic modalities which we have in recently to diagnose these systemic autoimmune disease will be in focus for today. Incidence of autoimmune disease 5 to 7% among the general population. I think we are just seeing the tip of the iceberg, because 5 years down the line, 10 years down the line, this incidence will be doubled for sure. And when the data comes, and we will come to know that this is just a very, very low incidence which has been published in the index journals. Definitely, this diseases are more common in females as compared to males. And you see the global autoimmune diagnostic test market is predicted to reach $14.2 billion by 2023. And we are yet to receive the data for 2024. So lots and lots of new, you can say, diagnostic companies are coming up with different, with a battery of investigation, battery of new tests which are there. And when we talk about the historical aspects of ANA, now we all know that ANA is the basic screening tool for first line screening tool for the diagnosis of organ specific and systemic autoimmune disease. Now, ANA stands for anti-nuclear antibodies. That means that the antibodies are directed against the nucleus of a cell. But let me take a moment to tell you that maybe a couple of years down the line, this terminology of ANA will be replaced by ACA. ACA stands for anti-cellular antibodies. Why? Because it has been now proven that the antibodies are not only directed against the nucleus, but they are also directed against the cytoplasm. So maybe the new ICAP guidelines which are coming, the international consensus for ANA pattern reporting, they have categorically termed different patterns, the, you can say, the commoner patterns, the expert patterns, into AC, AC1, AC2, AC6, AC7, anticellular. AC stands for anticellular. So maybe anti-nuclear antibodies, the terminology may be changed to anticellular antibodies. But right now, we are into the area when immunofluorescence, line immunoassay, chemiluminescence are there. But what was there in 1940s and 1950s? We had very, very, you can say, uh, primitive tool to diagnose systemic autoimmune disease, and that was LE cell. Slide is not. Next. Yeah. So I purposely had pasted a black and white photograph. You can see on the left side is an LE cell. Now, it was a serendipitous discovery at Mayo Clinic by Hargraves and et al. They noted some atypical cells in the suspicious patient of a lupus in the marrow, and but they noticed that the positivity was just 40%. That means 10 cases of lupus, 4 out of the 10 cases might have. 60 years down the line, we are into NA immunofluorescence with positivity of 95 to 100% in the cases of lupus. So, but that doesn't underline that the LE cell should be obsolete. There are a few cases, interesting cases, which we have seen at our lab where everything failed, and we could have a definite diagnosis of a systemic autoimmune disease with the help of an LE cell. So also, I would like to share one of the cases. One of the cases was of a 10-year diagnostic case of lupus. and she was on already on you can say immunosuppressive therapy and steroids, and she developed a bilateral pleural effusion. Now, a 10-year-old girl uh, with lupus with bilateral pleural effusion, the pediatric rheumatologist wanted to know whether that whether that pleural effusion was because of tuberculosis or something else. So they called up. They had sent the fluid sample to us, and it was a lymphocytic exudate, but the ADA was not very highly raised, it was marginally raised. So there was a dilemma whether the effusion is tubercular or something else. So definitely we did an ANA. Of course, an ANA was positive for that fluid, but more likely when we prepared LE cells, the LE cells were also positive on that fluid. So likely the diagnosis was a lupus pleurisy rather than a tuberculosis. So when we talk about anti-nuclear antibodies, they are the autoantibodies which binds to the nucleus of the cell. Very important that ANA is not only specific for autoimmune disease, but they can be seen in such as chronic infectious disease like infection, mononucleosis, tuberculosis, lymphoproliferative disorders, and in even normal healthy individuals in low titers. So when we are ordering a ANA or when we are reporting an ANA, we must see couple of things. We must go back to our guidelines. We must realize that are we seeing some sort of a pattern? What is the dilution? What is the intensity? And then are we able to figure out that we are seeing one or more patterns? Because the guidelines have now changed. I would also show you the guidelines, what are there. And more commonly in Indian practice, when we see the test to diagnose ANA is IFA and ELISA. So many of the labs which are using where they are using ELISA because immunofluorescence requires technical expertise. Not everyone is trained to report immunofluorescence. So ELISA is the more commonest investigation which is available pan India, but definitely the specificity when compared to immunofluorescence is less, and you can say false positivity is more in ELISA because of contamination. And if you get a positive result in ELISA, you are nowhere. But when we compare this technique with immunofluorescence, the pattern and the dilution, it helps us to point towards a specific autoimmune disease. That is why IFA is gold standard as per American College of Rheumatology. So it has got a diagnostic edge over ELISA. ELISA, I would recommend if we are screening a large number of population, and we must have a robust technique. That means if we are using automation in ELISA, uh, it will be more handy and it will be avoiding a false positive or a contamination. We did an internal study also. The agreement, you can say the ELISA versus immunofluorescence, the agreement that a serum ANA is positive with IFA was 87% to 95% when we compared with ELISA. So we have made our ELISA also very much robust. It's not that we are not reporting ELISA, we are also reporting ELISA, but we are using an automated platform. But see the variation in the sensitivity of ELISA, 69 to 98%, 30% in the variation. So I'm sure that our patients cannot have these reports with 30% of variation coming up. And these figures were arrived when we used a sera titers of 1 is to 160, which is considered uh, very much for the next line of investigation. If you ask me the significant titer, it's also as per literature 1 is to 160, which warrants the next line of investigations. And the practice of testing ANA has changed from past 10 years. We were screening in 1 is to 40, then we used to screen in 1 is to 80. Couple of labs are now shifted from 1 is to 80 to 1 is to 100. And ACR guidelines, which I would like to show in the coming slides also gives an ANA of entry criteria of 1 is much important. So where does ELISA stand? It should be used if immunofluorescence is not available, and it should be used for screening large population. And all equivocal or borderline results of ELISA must be rechecked by immunofluorescence. And automated platforms for ELISA provide more testing accuracy and also helps to overcome the issue of false positive cases. And this is the ACR positional statement that immunofluorescence is the gold standard. And all the hospital labs or the tertiary care labs which are using different technologies apart from immunofluorescence, now they should specify the method which they are using. That the sensitivity and the specificity should be in line with immunofluorescence if they are not using immunofluorescence. So that is a positional statement by American College of Dermatology. This is the 2019 ACR Euler criteria for lupus. Now, this is a very, very important criteria which was published in 2019. Now, you can say that ANA has been given an entry criteria with a titer of more than equal to 1 is to 80 on Hep2 cells. Very, very important. That means if you are suspecting your patient to have lupus, then first line of investigation will be ANA, and please make sure that lab is testing ANA immunofluorescence in a dilution of 1 is to 80 or more, because there were issues in 1 is to 40 and now even in 1 is to 80 that we are getting false positive ANA. So higher the dilution, the higher the titers, more are the titers of ANA meaningful. And now they have given specific, you can see points on based on the clinical and the lab criteria. And if the total score is 10 or more in this classification, you can say the patient to be labeled as lupus. But how much emphasis they have given on the laboratory investigation, it's very, very imperative to see that if the specific antibodies which are positive for lupus, like anti-Smith and anti-dsDNA, they have given us 6 points. Then, if the levels of C3 and C4 are low, you get a 4 points. And for Epla syndrome also, if there is a positivity of beta-2 glycoprotein and anti-cardiolipin antibody, you get a 0.2. So in every case which you are suspecting for lupus, you are getting a homogeneous typical pattern, a strong homogeneous pattern, you will go for a anti-dsDNA. And if anti-dsDNA coming positive, straight away you get 6 points. And almost, you can say 99% of the cases of lupus presents with hypocomplementemia. That means the C3, C4 levels are low. So straight away, if your dsDNA is positive and C3, C4 levels are low, 6 plus 4 is 10. Almost the diagnosis of lupus has been made, irrespective of the fact that patient might be having symptoms. You can have a butterfly rash, photosensitivity, then some sort of a fever, low-grade fever, arthralgia, myalgia, thrombocytopenia. But so much emphasis has been given, 6 points to 4 points. And So that means the lab, it's a prime responsibility of the lab to have some of the sophisticated diagnostic modalities. Now, when we come to screening of ANA, now we are using AI. Now the time has come when we use artificial intelligence, and with the help of artificial intelligence, we are able to not only get the pattern, we are able to get the dilution, the intensity part also, and then post AI we are able to review an expert in IF reporting, let it be a pathologist or a microbiologist, can see again what AI has reported, so that you are doubly sure of your ANA reports. And these are the ICAP guidelines. It is divided into competent level and expert level. Now, all the labs who are practicing ANA IF must report their patterns according to the ICAP guidelines, and there are very, very few labs in India who are reporting at expert level. Most of the labs are reporting at the competent level. That means the more common patterns like homogeneous, speckled, centromere, nuclear dots, and so on. These are the more common patterns which are reporting. But we are reporting at the expert level, and definitely when we are reporting at the expert level, we need to uh, label the pattern according to the ICAP. Then ANA IFA importance is that the pattern seen are not absolutely specific for a particular disease, because many other autoantibodies may be present in combination, but few of the patterns like centromere, nucleolar, cytoplasmic pattern are very, 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 very specific. If you take an example of cytoplasmic pattern, now cytoplasmic pattern, if it is a strong positive cytoplasmic pattern, only three things will come into my mind. First will be an autoimmune liver disease, and it will be likely a primary biliary cirrhosis, maybe an autoimmune hepatitis also. First will be an autoimmune liver disease. Second, it can be a idiopathic inflammatory myositis, and it can be psoriasis. So how the pattern which we see are, you can see, limiting our diagnostic yield. So homogeneous, a typical homogeneous pattern is more likely patient might be having lupus. Speckle pattern, definitely the more common pattern, but when it comes, it opens lots and lots of, you can say, diseases pattern like rheumatoid arthritis, Sjogren syndrome, then mixed connective tissue disease. You can see one or more pattern, and you can see IFA is the most sensitive test for ANA because it's virtually positive in every patient of SLE, but not so specific because patients of other autoimmune diseases also score positive. And we must remind ourselves of the, when we talk about pros, we also should know about the cons, that 5 to 15% of the normal people have ANA positivity in the low titers. So we don't need to screen the patient for low titers. I think we should start with either 1 is to 80 or 1 is to 100, but we must see that the cutoff, that the significant titer is 1 is to 160. And if you are getting a titer of 1 is to 160, irrespective of any pattern, it warrants a next line of investigation, which is ANA profile or ANA blot. And few of the antibodies like anti-dsDNA and Smith are very, very specific. And for example, they are very specific for lupus. And a positive ANA in a patient with no symptoms of autoimmune disease is often of unclear. And as I already told, that a titer of more than equal to 160 is significant, and it warrants the next line of investigations. And 1 is to 80 dilution or more is included in the ACR Euler criteria for lupus. Patient with negative ANA is highly unlikely to have an autoimmune disorder. However, if still there is a strong suspicion and repeatedly your ANA is coming positive, then definitely directly you can go for an ANA profile. And depending upon the, you can see, signs and symptoms which patient is having, you can order a 15, 18 or a 23 antigen profile, or a separately you can order dsDNA anti-Smith. RNP, SSA, SSB, SEL70, and so on. Next. A very, very important feature of reporting ANA is that there's standardization and harmonization is a need of hour. See, many labs are reporting IF, but we are also getting this pattern and the dilution, sometimes samples for second opinion, because there's a general consensus which is required that ANA-IF testing is challenging because it requires a trained and skilled person with good experience in microscopy. We must be reminded that the microscopic optics, the light source, the lamp, dilution, and other factors does affect the quality of reporting, and these all needs to be standardized. However, definitely those labs who are using automation, that means automation in processing of the samples and even reporting, these shortcomings can be overcome, and it also reduces the inter-lab variability. And yes, definitely when it comes to reporting, we are reporting ANAIF, we are giving the patterns. We are the only lab pan India to have the immunofluorescence photograph in the patient reports for ANA, DNA in ANCA, because definitely when you are giving a pattern, you are giving an information that a particular pattern can be presented in a particular disease. So an information must be going on to the patient. And when it comes to ANCA, we must give whether the patient is having a P ANCA or a C ANCA, because definitely it carries importance. C ANCA is very common in venous granulomatosis. When we talk about ANCA-associated vasculitis, it will be dealt in the subsequent lectures. We have only three diseases coming up in the small vessel. ANCA-associated vasculitis is the Wegener's Church-Strauss syndrome and microscopic cholangitis. And again, these lectures will be dealt with the two techniques are available, ELISA and IFA. What are the guidelines? First, IFA should be done or ELISA should be done. But we are giving the immunofluorescence photographs in our patient report. Next. And even for dsDNA also, we are using this Crithidia substrate. I think this is very, very important because when we are reporting dsDNA, now there are two methods of reporting dsDNA, IF and ELISA. Now, people do say that we can go for IF, we can go for ELISA, but I will like to point out that ELISA, what edge ELISA has over IF is that at the time of diagnosis, you are getting a quantitative value beyond the cutoff, maybe 500, 600, 400 or so. And definitely when patient is on treatment and is maintaining compliance and is coming up after 3 months a follow-up, and we are doing a repeat dsDNA levels, and if they are coming down, it indicates a better prognosis, definitely. So dsDNA ELISA is a prognostic marker apart from a diagnostic marker. So ELISA has a edge in terms of a prognostic value, but dsDNA is not only the prognostic marker, the level of complements, the C3, C4 also helps us to determine whether the prognosis is in line with the treatment or not, because usually the patient presents with hypocomplementemia, and after 3 months or 6 months, when there are investigations are repeated, if the complement levels are coming normal, that means the patient is maintaining good compliance. Because why it is needed? Because the most commonest complication of SLE is lupus nephritis, and 50% of the cases of SLE, if not treated properly or if left untreated, land up in lupus nephritis and could land up in end stage renal disease. Next. So this is the ANA positivity in various autoimmune diseases, SLE 95 to 100% drug induced, 100%, and so on, coming to even juvenile rheumatoid arthritis, 15 to 30%. So irrespective of the incidence, the ANA still holds very good. It should be the first line of investigation, but it should be ordered very, very cautiously. It is not an investigation like CBC, LFT, KFT, which are ordered very, very commonly. ANA should be ordered if we are suspecting our patient to have a systemic autoimmune disease in line with some of the criteria which are given for different types of disease, because if ANA comes positive in low dilution, then the patient and the clinician both is in dilemma whether you want to go for a next line of investigation. They are very, very costly, and patient ends up in spending thousand and thousand of rupees, and ultimately he or she is concluded to have no autoimmune disease. Next. Now, I say the pattern, there are more common patterns. You can say I've shown homogeneous pattern. This is the speckled pattern, nucleolar pattern, and cytoplasmic. These are more common pattern. And if you are getting this pattern, they are coming 3 plus, 4 plus, strongly positive, or even 1 is to 160, or even low titers. Low titers are also significant, especially when it is in line with the clinical history and with the signs and symptoms of the patient. So it cannot be neglected. So when we are seeing such of the patterns, the next line of investigation to confirm uh, whether the patient is having an autoimmune disease is the LIA, is the line immunoassay. Although there are different technologies, multiplex assays, different types of, even CLIA, ELISA are coming up, but still we feel that line immunoassay, though it is not a quantitative estimation, but still I feel it is the gold standard right now because of its good sensitivity. So we have this line immunoassay is almost a modified technique for Western blot, which we are using. And it is fully automated. The test is fully automated. There's a control band which is coming up, and the intensity of uh, different antibodies which is coming up is measured against this control band. And this is also measured not by the naked eye, me or my technical staff or my colleague. It's a totally inbuilt software with the can say the camera inside, and the intensity of the control band is read against these different you can say antibodies. And the RNP SM for mixed connective tissue disease, SM is for lupus, SSA, SSB, RO52 is for Sjogren syndrome, SCL70, PMSCL for scleroderma, JO1 for against dermatomyositis and polymyositis, or you can say idiopathic inflammatory myositis. The centromere is for CREST syndrome. dsDNA is again for, you can say, lupus, nucleosome, histones, riboproteins are for lupus. AMAM2, it is given separately for organ-specific autoimmune disease. AMA stands for anti-mitochondrial antibody, which is very, very specific for primary biliary cirrhosis. Next. Now, this is a very, very, I can say, lucid algorithm. You're getting a positive ANA, different patterns. You are able to see the peripheral, homogeneous, speckled, nucleolar. Accordingly, you can go for the line of investigations. Cytoplasmic pattern, I told only 3 diseases are likely to have, depending upon the signs and symptoms the patient is having. You can go for a, if you're thinking about myositis, you can go for a GO1. If you're thinking in terms of primary biliary cirrhosis, you can go for an anti-mitochondrial antibody. And then centromere pattern, very common for CREST syndrome. I think if you are getting a centromere pattern on ANA, even strong, you will not be even requiring a ANA profile for that, because the centromere pattern is very, very specific for CREST syndromes. And the nucleolar pattern more likely going towards scleroderma. Speckle pattern is a more common pattern. It opens up, patient might be having rheumatoid arthritis, mixed connective tissue disease, and even SLE, and even scleroderma. It can be a limited one or a diffuse one, but definitely the pattern helps us. And when we talk about how the pattern helps us, we should be aware that what are the signs and symptoms our patient is having, and in line what the lab has given the pattern, the next line of investigations can be ordered in terms of ANA profile. It is available in 15, 18, and 23 antigens. Now, why there are 3 profiles which are available? Because in 23 and 18 profiles, you can have some sort of, they have added organ-specific also, organ-specific antibodies also, apart from systemic autoimmune disease. So 23 antigens profile is the present in Indian scenario is the most you can say, the largest profile for screening. Next. Again, on the left side is the diseases, on the right side is the associated antibodies. For Sjogren's, we have SSA, SSB. For scleroderma, CL70, dermatitis JO1, CREST syndrome, centromere, drug-induced SLE, and then scleroderma, then rheumatoid arthritis. We have got rheumatoid factor and anti-CCP antibodies. Both are, I think, anti-CCP is more specific for rheumatoid arthritis, and it's more specific for even cirrhosis rheumatoid arthritis. Anti-CCP also has a role in prognosis, also especially in erosive, you can say, rheumatoid arthritis. And there is a upcoming marker in for the diagnosis of rheumatoid arthritis, and that was known as Mullerian citrullinated vimentin, MCV, is a new marker which is coming up. MCV, Mullerian citrullinated vimentin, but not many studies have been done on this. We're trying to validate on that how promising that MCV will be there in comparison to anti-CCP. Next. And there are so many, you can say, so many diagnostic test scores and tests which are available. Probably why? Because we are having the Center for Excellence in the diagnosis of autoimmunity. So we have got the battery of tests and the techniques which are available, more than one technique for a test which is available. And it's first of the kind for Center for Excellence Pan India. We have launched on the theme of Mayo Clinic, and we are trying to match the test menu which Mayo Clinic are doing right now. But definitely there are many kits for which the license is not available in India. But definitely when it comes to testing for autoimmunity, we try our level best to give patients the best possible report in the best possible time. And even you can say for disease specific panel, we have Sjogren syndrome panel, scleroderma panel, and then SLE panel, anti-synthetase syndrome, very, very important now, which includes interstitial lung disease, rheumatoid arthritis, myositis, and not very uncommon, then autoimmune interstitial lung disease panel, the ANCA-associated vasculitis panel. I say some of the labs are now testing ANCA via LIA also, apart from ELISA and immunofluorescence. Next. So, take home message, the screening for autoimmune disorders via ANA must be only done if there is a strong clinical suspicion. The ANA should be ordered, and we must be reminded that 15 to 20% of the normal healthy individuals have ANA in low titers. Immunofluorescence is the gold standard as per American College of Rheumatology. Higher titers are more meaningful. That means if you are getting a titers of 160 or more, definitely you can go for reflex testing, or you can order a next line of investigation. Next. And if there is a suspicion of an emerging autoimmune disease, then a previous negative ANA test can be repeated definitely. And when it comes to ANA testing, now there is something you should say, that people are going for repeated ANA of autoimmune disease, and your ANA is coming negative, repeatedly it's coming negative, then that negative ANA report should be negated, and instead ANA profile should be straight away ordered. And high titers of ANA are usually sensitive, and further ANA profile should be done. False positive ANA, I have told you, is seen in lots of chronic conditions and on patients on some drugs like captopril, procainamide, phenytoin, quinidine, sulfasalazine, and interferon. So we must be reminded that we must keep in mind when we are ordering ANA test, because there is a chance of coming false positive, which lands up in trouble, and unnecessary next profile ordering, and then maybe the costing, it does matter. Next. So couple of new tests which we have now. This is the PSPT now. We have launched this. We are the first pan India to launch this test. This is the phosphatidylserine prothrombin, and this test is included in the APLA panel. We know about antiphospholipid syndrome. Now, this test is right now included in tier 2. We have got beta 2 glycoprotein, cardiolipin, and lupus anticoagulant, which play the pivotal role. And it is now, right now, phosphatidylserine PSPT is in tier 2. So, but when we did the validation studies, it has got an equal sensitivity and specificity with cardiolipin and beta 2 glycoprotein. So, I wanted to emphasize on this. Next. And even HMG-CR, when we talk about myostatus, and in Indian scenario, people are using statins. Now, statin-induced myositis is very, very common in India, and HMG-CR is one of the important tests to diagnose statin-induced myositis. Next. And any guesses, you can write in the chat box for the audience who are there. So please don't write Michael Jackson. We all know he is Michael Jackson. But what Michael Jackson is having, yeah, it's coming SLE. Somebody has written SLE. So you can see a typical butterfly rash, which is so it is, yeah, butterfly rash. It's coming as somebody replied to that. SLE again, it's coming from Dr. Reena. Okay. So it is said that Michael Jackson was diagnosed with lupus at the age of 35 to 36. We didn't knew about that. And he used to undergo plastic surgery. And again, you can see that round red circle, that rash used to come back. And after the plastic surgery, so definitely the butterfly rash is not going anywhere, irrespective of his plastic surgery. But the most important thing was that he died at the age of 56 or 57. So 20 years down the line, he had SLE, and he didn't show that he's having SLE because he used to dance, he used to entertain us. And we all know about Michael Jackson. He used to carry battery of doctors, battery of ambulances, even blood bank, and he wanted to live more than 100 years. Unfortunately, so the motto of keeping this slide is that early you catch hold of an autoimmune disease, the early you diagnose it, the early you start the treatment, the better is the prognosis. So in today's era, when we have got most sophisticated diagnostic modalities which are available, so we should not miss the diagnosis of autoimmune disorders. Thank you very much. And if there are any questions, I hand over to moderator. Thank you.
Thank you, Ajay.
Ma'am, there are some chat questions.
Yeah, thanks, Ajay, for a very lucid presentation. There are two questions for you, Ajay. One is,
Yeah.
when ANA repeatedly comes weekly positive, does it affect the healthy pregnancy? This is by Dr. Jigna.
Now we need to see ANA coming weekly positive. Okay. Now ANA coming weekly positive means we need to understand how much is the titer which is coming up. It is 1:80, 100 or what? And we must see the history of the patient. Is the patient is having a bad obstetric history or not? I want to understand, because even if the patient is having bad obstetric history and ANA is coming weekly positive, then we must emphasize on this, and we must try to figure out why that ANA is coming weekly positive. For example, if the patient is pregnant for the first time and the ANA is coming weekly positive, then again we have to see the condition of the patient, and likely, unlikely, she might be having some sort of autoimmune disease. But depending on the history, if there is a BOH, if there is a history of previous abortion, then weak ANA needs to be considered, and further evaluation should be done for a APLA profile.
Ajay, just to add on to this, what do you think would be the role of medication in this case? If the patient has received any treatment, would it affect your ANA result?
Ma'am, it can be or it cannot be. It may be or it's not necessary, but it depends on, again, that which of the medications she has taken.
Yeah, can I just request Dr. Ranjan to throw us some light on this aspect, Dr. Ranjan?
Yeah, very good evening to everyone. So these questions which are related to clinical aspects, so I'll just try to answer this question regarding the pregnancy issue. So when ANA comes repeatedly positive, it usually has no bearing on pregnancy. So first of all, if a patient is only weakly positive, patient doesn't have any other features to suggest that patient has got a rheumatic disease, we need to remember that ANA positivity is more in ladies. It increases with age, and it can be a transient chance positivity when patient is having mild fever, some viral infection, or maybe other diseases which are not rheumatic. Now I see there was a comment. I think this lady had lost a pregnancy at 8 months. I think the person who had put the question has given a clarification.
Yeah.
So where now we have a patient who has lost a pregnancy at 8 months, which is quite significant. And then the patient is ANA positive. We need to rule out a possibility of APLA syndrome, because APLA
Absolutely.
itself can have 40% positivity for ANA. So saying that APLA usually does not require ANA to be positive, but if a patient has got a suggestive history and then ANA is positive, I would like to investigate this patient further, as Dr. Ajay Gupta has also highlighted.
Absolutely.
Thank you, Dr. Ranjan. The second question to you, Ajay, is what is your opinion about pediatric ANA dilution? I mean, if you
Yeah,
have a pediatric sample, does the dilution or the ranges change?
absolutely, ma'am. It's a very, very relevant question, and not only for ANA, it is also for organ-specific diseases like autoimmune hepatitis and primary biliary cirrhosis. A much lower dilution is requested for pediatric age group. Even 1 is to 20 for
Thank
ANA,
you.
1 is to 20 for ANA, 1 is to 40 for ANA, and 1 is to 10 for LKM, 1 is to 10, 1 is to 20 for AMA and ASMA. So a lower dilution for pediatric population is requested, and we should go for the lower dilution in pediatric age group.
Yeah, just to add to it, Dr. Reena, usually most of the labs for pediatric ANA do 1 into 20, 1 is to 20 as the initial dilution for the pediatric age group. The last question that is there is, what are immunomodulators? Is there a role of immunomodulators in autoimmune diseases like vasculitis, scleroderma?
Okay, that is Dr. Ranjan can answer.
Dr. Ranjan, please could you address this one?
So, ma'am, immunomodulators are the drugs which are called disease-modifying agents also. Like we usually use methotrexate, sulfasalazine, azathioprine, mycophenolate. These are all immunomodulators. If you talk about their use in rheumatic diseases, yes, different drugs have got different response in different diseases. It's not that every single patient needs to be given methotrexate. Methotrexate has a different efficacy in rheumatoid arthritis as compared to spondyloarthropathy as compared to in lupus nephritis. So same drug is not given to the same people, and it does have a role in vasculitis as well as in scleroderma in various manifestations, again depending upon the drug which we are using.
Thank you. One more question is whether autoimmune disorder can be controlled or prevented by proper nutrition.
Yeah, so I think the answer is no. There is nothing that has been found so far that I can say you take this, be it nowadays in fashion like chia seeds and other things, that will prevent autoimmune diseases. Yes, there are a few dietary modifications that can ameliorate the disease in a way for a particular set of patients. So the what I would like to say is that you would have listened, you would have heard that patients do complain that whenever I take milk, I take curd, I take sour items, my pains increase. Scientifically, till date, we have no basis for it. But yes, this has been found, complained by multiple patients, and then we say that whatever suits you, you should stop. As such, scientifically asking, we have no dietary advices for you. But yes, nowadays you must have heard of these studies which are coming from gut microbiota, and I think all these complaints have a basis which we may not have been able to find out so far. But I think in future we may be able to say that curd and milk contain so many bacteria, and this particular bacteria and this particular genetic background has a propensity to cause an autoimmune disease or give a flare of an autoimmune disease. So that may be the basis of what we hear from the patients.
Thank you, Dr. Ranjan. Just a comment on this. I remember hearing Professor Schoenfield. He has multiple such articles on various things, uh, just not food, but any and everything about its impact on autoimmune disorders. So maybe in time to come, we could have some real data which would tell the clinician as well as the lab as to what it could be and what could be the, the 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 factor for these autoimmune disorders to get triggered. I have one question, Ajay, probably the last one. I take it because I'm the moderator. Looking at the time,
Yeah, ma'am.
Ajay, what were
Yeah,
the
ma'am.
expert patterns that you got, and how do you classify them? What are the names given to them? If you could just share a few of them before we go on to our next speaker. Thank you.
Anything like mitotic patterns, intercellular, you can say mitotic spindle pattern is there, then rods and rings patterns are there. So a couple of these patterns are there which are classified under expert pattern. Rods and
How do you
rings, you can say
relate them to the
spindles.
extractable nuclear antigens and the diseases?
So if, for example, if we talk about now rods and ring pattern, now it is said that it can be associated with autoimmune disease or it can be associated with even hepatitis C. So all as as the new patterns are discovered and we are correlating with systemic autoimmune disease, more and more research is going on these new you can say the expert patterns which are coming up. So I would cite an example of rods and rings. We have seen about, you can say, 20-25 cases, and we even had tried to go for their hepatitis C markers and all, but I could not get that. And even clinical profile also that they had some vague arthralgia, vague energy or fever and all, no specific symptoms, but we are getting a rods and ring pattern. So I
Would
think
autoimmune hepatitis have a cytoplasmic pattern as well, or do you see cytoplasmic plus rod and rings?
Uh, autoimmune hepatitis have both cytoplasmic rods and rings, and but primary biliary cirrhosis more likely goes towards the cytoplasmic pattern.